So good morning, everyone. So now it's already 11 on my computer clock. So we shall start on time. And for your information, this our MGH is actually recorded, and we will make the recording available later on. Okay, so for those who have just joined us in these sessions of Meta Journal Hour, it is a 1 hour or plus sessions to appraise some important research papers. Basically, is to learn how people did their research, how they report their research, and then after we are clear about their methods, then we'll try to understand the results. And if relevant and possible and useful, we want to apply the result in our life. Yeah. So the Meta Journal Hour is an hour's kind of a session so that we can scrutinize other people's work. And I think this is one of the steps for researcher to learn from each other, from the bad, from the good, so that we can do a better research in our future project. Okay, so this is the purpose of our MJH for those who have just joined us for in these sessions. Right, so for this MJH series 3, we have chosen a Korean paper entitled Physical Activity and the Risk of SARS-CoV-2 Infection, Severe COVID-19 Illness, and COVID-19 Related Mortality in South Korea. Yeah, so it's a nationwide cohort study by a group of Korean researcher. Okay, and we know that this paper is very relevant at this time in Malaysia, and many of us are in the midst of probably don't know how many wave, the 5th wave of COVID-19, and you want to know how we can do or what we can do to reduce our risk of getting COVID-19. Yeah, and if we do get it, what we can do so that we don't get a severe one. Yeah, so we can recover faster. So essentially, and this paper, if it's relevant to us, you may want to use it among your family members, among your customers, among your whoever that you know, to advise them what else they can do, or what exactly physical activity we can do to reduce the risk of COVID-19. Okay, so I would like to again welcome Miss Nurul Iman, our research officer in CRU, to share with us this paper. Okay, over to you, Iman.
Thank you, Prof. Chu, for the kind introduction. So let's just begin our session for today. Okay, so for this week, we are going to appraise this article as mentioned by Prof. Chu, in which that it is entitled Physical Activity and the Risk of SARS-CoV-2 Infection and its risk in related with severe COVID-19 illness and also COVID-19 related mortality in South Korea, in which that this study is a nationwide cohort study involving adult Korean population. So before we begin our session, so this is just the introduction in which that throughout our MDH session, I am going to utilize the list in which that this is what we call as critical appraisal skills program, in which that whenever that we are appraising a research article or whenever you are reading a research article, this is the list that you can use to actually appraise a research paper. So they do have appraisal for RCT, which is the randomized clinical trial, for systematic review, and as for today, I'm going to use this checklist, which is for the cohort study checklist. As for the introduction, first is related with physical activity and mortality. So sufficient physical activity is actually widely known to be associated with decreased risk for all cause and also disease-specific mortality, especially in related with chronic disease like metabolic syndrome, type 2 diabetes, cancer, cardiovascular disease, and it's also related with improved physical function, cognition, and as well as quality of life. So this may be related with the protective benefits of physical activities, in which that many previous studies have suggested that physical activity has a protective effect against the infectivity and also severity of respiratory infection due to its many immunological benefits. So what are the optimal dosing of physical activity? So the World Health Organization has actually suggested a minimum of 150 minutes of physical activity to 300 minutes of physical activity of moderate intensity physical activity that can provide substantial health benefits for all the said benefits. But what about physical activity and COVID-19? So the worldwide restriction imposed has actually shown that there would be a decrease in people's daily behavior, routine, and also population levels of physical activity, which may subsequently lead to an unhealthy lifestyle. So, although that physical activity has been shown that it is beneficial to the immune system, but then the impact of physical activity itself and also the association of the activity itself specifically on the COVID-19 infectivity and also its clinical outcomes still remains unclear due to this pandemic has just occur like around 1 or 2 years time. So there are many lacking in terms of studies investigating the association with physical activity together with the COVID-19 infectivity and its related clinical outcomes. So what are the research questions that this study is going to address? So first, does sufficient physical activity reduce the risk of COVID-19 infectivity, severity, and its related mortality among patients who underwent the SARS-CoV-2 testing? Or does physical activity actually decrease the length of hospital stay among patients that has already confirmed with COVID-19? So when we are looking at the research questions, we can see that the research questions address a sufficient research gap which has not been addressed before, and this study also involved a large scale of retrospective study regarding physical activity and also COVID-19 infectivity. So to answer the research question, so the research objective for this study is to investigate the hypothesis that sufficient physical activity reduce the risk of COVID-19 infectivity, severity, and also its related mortality among patients who underwent the SARS-CoV-2 testing, or decrease the length of hospital stay among patients confirmed with COVID-19. So note the word here, which is the sufficient, in which that this study is going to address as a certain amount of physical activity is actually able or not able to reduce the risk of COVID-19 infectivity. So the keyword here is sufficient. Okay. And then in terms of the materials and method of this study, so where did the study get their data? So the source of the data is from the Korean National Health Insurance Service, in which that they contain all the data of individuals who actually went the SARS-CoV-2 testing in South Korea service, which is facilitated by their Korea Disease Control and also Prevention Agency by the Ministry of Health South Korea. So actually they have this kind of database in which that they have the researchers have the access, and the data set contain the general health examination result, the national COVID-19 related registers, including COVID-19 related outcomes and death records. They also have the data on the health insurance data for the past 5 years, including the insurance eligibility data, outpatient, inpatient healthcare records, and also pharmaceutical visits. So it's kind of a comprehensive database that they have. So the duration for patient recruitment is actually between the 1st of January 2020 to the 30th May of 2020, which is around 5 months. Okay, and then in terms of the characteristic of the data set, so the Korean government provided complimentary and mandatory health services and insurance to all Korean patients with COVID-19. So that's why they have this set of data that is accessible for the researchers. And besides that, they also have the data on COVID-19 related death and also outcome records. But then it should be noted that all this data, all this patient-related data were actually anonymized to ensure that the data is confidential for the patient's record. Okay, so in terms of the study population, so again, so this is all Korean individuals in which that they must age more than 20 years old, who actually underwent the SARS-CoV-2 testing between the 1st January 2020 to the 30th May 2020, and the infection of COVID-19 must be confirmed via the RT-PCR test. But then please be noted that the 200,000 here is all the individuals underwent the testing itself. Nevertheless, or regardless that they are positive or not. So they actually recruited those who are undergoing the test first. And then those individuals were actually linked with the National General Health Examination data, in which that the data was obtained from 1st January 2018 and 31st December 2019 to obtain data on level of physical activity. So it is a retrospective data. So they obtained the data on the individuals who underwent the COVID-19 test, but then the data on the physical activity was the retrospective data, in which that it was obtained from the National General Health Examination data, in which that one of the assessment that they have undergone is the physical activity.
Okay, yeah, Iman, just pause for a while. So for those who are here, you feel free to on your video and say anything or ask any questions. Yeah, make this session as interactive as possible, so that you may benefit from the session the most. Yeah, rather than watching the sessions later like others, you have the opportunity to ask questions and to post your query about the paper. So we try to understand and learn from the paper, and we try to also explain if we can, yeah, on any points that is important in this paper. Yeah. Otherwise, the presentation will goes on. Okay.
Okay, thank you, Prof. Chu. Okay, so in terms of the critical appraisal checklist, because this study is a retrospective cohort study, so was the cohort recruited in an acceptable way? So because of the outcome was the COVID-19 infection itself, so the researcher actually included all Korean adults who are undergoing the RT-PCR test were actually recruited in the study. So the cohort actually, the study actually tried to recruit as many as adults or as many as participants as possible. So that's why they included all the Korean adults who has undergone the RT-PCR test into the study. So what are the kind of other data that included from the general health examination? So this one is the retrospective data. Okay, so what are the kind of data besides the lifestyle activity, besides the physical activity? So these are the data that they obtain. First is on the socio-economic background, which is comprised of gender, age, household income, region of residence, were all obtained from the insurance eligibility data. And then they also has access to the lifestyle habit, which includes the smoking habits and also frequency of alcohol consumption, the comorbidities and also medication history, in which that the comorbidities must be from the history of physician diagnosed disease and also medication in related with diabetes mellitus, tuberculosis, stroke, cardiovascular disease, hypertension, dyslipidemia, and these were all obtained from the general health examination. And also they also have the self-reported questionnaire, for example, like physical activity and also personal medical interview to assess the general health of the population. And then on top of that, they also have the health assessment data, which includes the body mass index, the systolic and diastolic blood pressure, the blood glucose, and also creatinine for estimating the glomerular filtration rate, which is to see the kidney function of an individual. And also the total cholesterol was obtained from the fasting serum samples during the general health examination. So we can see that they have quite a comprehensive data in regarding with their participants of the study. Okay, so going on to the exposure and outcomes of the study. So the exposure is the independent variables and the outcome is the dependent variables of the study. So let's look at the exposure. So the exposure of this study is the levels of the physical activities, in which the levels of physical activities is measured by two ways in this study. First is through the general recommendation of physical activity recommended by the World Health Organization, in which that the general recommendation would be a recommendation of more than 150 minutes per week of moderate intensity or more than 75 minutes per week of vigorous intensity and more than 2 times of muscle strengthening activity. So from this recommendation, they further categorize it into those who are having insufficient aerobic activity and muscle strengthening, those who are having sufficient muscle strengthening activity only, those who are having sufficient aerobic activity only, and lastly is those who are actually having both sufficient aerobic activity and also muscle strengthening activity. So that there are actually 4 groups of levels of physical activity here. And then the second category of physical activity is based on the metabolic equivalent task, which is the MET score is basically how much energy that you are spending based on what kind of activity that a person is doing. Okay, so this metabolic equivalent task MAT score is also categorized into 4 categories, which is 0 MET score is actually inactive, and then 0 to less than 500 MET minute per week is insufficiently active, 500 to less than 1000 is considered as active, and more than 1000 MET score per week is considered as highly active. Okay, but then in the method part of the paper itself, if you have the paper with you, you can see that actually the author does not really specify on how they actually classify their MET score. But then from the general MET score classification, it should be based on what kind of activity that you are doing. So let's say the MET score for gardening would not be the same like if you are running 100 meters or if you are doing any swimming or if you are doing any vigorous activity. So the higher energy that you need to do a specific activity, the higher the MET score would be. So this is based on the levels of physical activity. And then for the dependent variables, which is the outcome of this study, so the primary outcome of this study is the positivity of the COVID-19, which is test positive for the RT-PCR test, and then severe COVID-19 illness, which is defined as the ICU admission and also administration of invasive ventilation, and also severe COVID-19 related death. And then the subgroup outcome of this primary outcome is the length of hospital stay for those patients who actually tested positive for COVID-19.
Yeah, Iman, just allow me to emphasize and highlight to you, you have to remember the exposure here. Because later on, all the results you want to apply later on is actually you need to understand this level of, this categorization and this level of physical activity. Yeah, so you look at ourselves, do we actually exercise moderately, 150 minutes per week? Or do we exercise vigorously, 75 minutes per week or not? Yeah, if we are not doing that now, so whatever the result that later you see, is not going to apply on ourselves lah. But if you want to use the result and changing your physical activity, then you have to do up to this level. Then the result of this paper will be applicable to you. Okay.
Okay, so when we are talking about exposure and outcome, there would also be checklists on how to actually appraise how whether the exposure and outcome was actually accurately measured. So in this study, the exposure in this study was actually physical activity, and the authors has clearly stated on how they would actually measure their physical activity. So first is based on the recommended guideline, which is recommended by WHO, and the second one is based on the MET score. So these two guidelines or these two recommendations are both validated recommendations. And then in terms of the outcomes measure, so the measurement of the outcomes were also clearly stated in which that the patients must be tested positive for COVID-19 infection. So it must, in terms of the severe COVID-19, they also have clearly define the outline the definition, and also in terms of COVID-19 death and also length of hospital stay. So in terms of the checklist of the appraiser, so you can actually look at the hint here. So whenever you are appraising research article, they actually have give you the hint here. So what are the kinds of what are the components that you can look at in terms of appraising the measurement of exposure and also of the outcome. Okay, and then in terms of the analysis, so in this study, they actually classify or they actually categorize their subjects into 8 cohorts. So there are 8 cohorts in terms of the levels of physical activity itself. So the purpose of categorizing the subjects into 8 cohorts is for robustness and also for the generalization of the results. So let's say that we are going to see later on, no matter whether you are using MAP score or whether you are using the level of 150 minutes per week, so which are the kind of categories of physical activity that can actually protect from COVID-19 illness and also COVID-19 infectivity. So we will look at the cohort first. So first we have cohort A and cohort B. So this is the eligibility criteria to enter to the study. Must be over 20 years of age, at least one SARS-CoV-2 testing, and also they must have the general health examination data in South Korea. So if they tick all these eligibility criteria, so they can enter the study. So the data is between 2018 to 2020. So this is where they would obtain their general health examination data. So cohort A and cohort B subjects categorized under this cohort is actually categorized based on the WHO recommendation, which is they would have 4 groups. First, the insufficient aerobic and muscle strengthening activity, whether they have muscle strengthening activity only, whether they have aerobic activity only, and whether they have both sufficient aerobic and also muscle strengthening activity. And this is all the primary outcomes that we have seen in our previous slide before. What are the outcome, or what are the dependent variables they are looking at? Okay, so this one is for cohort A and cohort B, in which they are looking at the categorization based on the WHO categorization. Okay, so when we broke it down into numbers, so you can see that there are around 76,000 of participants in study cohort A, in which that it is broken down into 4 more groups, whether they are having insufficient, both insufficient activity, or whether they are only doing muscle strengthening activity, or whether they are only doing aerobic activity, or they are doing both sufficient aerobic and also muscle strengthening activity. And then because they have all these different numbers. So the researcher actually did the propensity score matching in cohort A. So propensity score matching actually purpose to actually divided the subjects into 2 comparable groups, which have almost or comparable baseline characteristic, because in randomized control trial you can actually randomize our subject, but because this is an observational study. Okay, so we cannot really actually randomize our subject into groups, because the subject's already there, the data is there. So what can we do is actually to do the propensity score matching. So that's why they have this equivalent number of those subjects in, or those participants in insufficient aerobic and muscle strengthening activity, and another comparable group is in aerobic and also muscle strengthening activity. Okay, so this one is on the propensity score. And then under the study cohort A also, they also categorize another subgroup of the subject, or the participants who actually tested positive for the SARS-CoV-2, which will be categorized under the cohort B. But under this cohort B, they did not do this propensity score matching, only the cohort A. Okay, any questions on this part before we move on, because there are also other cohorts that they are going to do this propensity score matching? Or any additional points that you would like to add, Prof. Chip?
Just want to add on the propensity score is a method, multivariable methods of actually getting the 2 comparable groups in the dataset, comparable in terms of prognostic factors, or those factors that the study capture, so that these 2 groups are comparable in all other things, except the exercise category of as stated on the slide. And then they want to see whether holding all the other factors are similar, whether having the difference in the category of physical activity has anything, is there any different or effect on the outcome? That's what the propensity score, the beauty of it in a non-randomized data set. Okay.
Okay, so this is on cohort A and cohort B. So we will move on with cohort C, which is the 3rd cohort. So cohort C is also the same in terms of its eligibility criteria, and also the duration where they will obtain the general health examination data. But the differences, cohort C and also the next subsequent cohort with cohort A and cohort B is actually the categorization of physical activity. Because from cohort C onwards, the categorization of physical activity is based on the MAT score, in which that it is based on these four categories, whether the participants, whether the subjects are inactive, insufficiently active, active, or highly active. And the primary outcomes are still the same with with all the cohorts. Only that the exposure in terms of the categorization of physical activity is different. Okay, so in terms of cohort C, so they would be for categorization, but then also like match cohort A, they also do propensity score matching to actually have these two comparable groups of insufficient physical activity and also sufficient physical activity. So in propensity score match cohort C, those with inactive and also insufficiently active will be categorized under this insufficient physical activity. That's why they have around 29, almost 30,000 of participants, and also the same number with sufficient physical activity, in which that those who have MAT score more than 500 will be categorized under this sufficient physical activity. So they would have these two groups to compare. Okay, and then they have cohort D and cohort E. So for cohort D and cohort E, the data for the National General Health Examination is actually obtained from the year of 2015. If you notice, for cohort C, it is from 2018. But then for cohort D and cohort E, it is from January 2015 to January 2020. So they would have a larger number of participants in that study. And they would also compare their participants in terms of the MAT score, in terms of the metabolic equivalent task score, and same primary outcomes. Okay, so for cohort D and cohort E, they are only using the MAT score because the author claimed that in Korea, from 2018 and before, and in the previous years, they don't have data on the muscle strengthening activity. Because if you want to use the other classification, they have to have the data on muscle strengthening activity. But then for the MAT score activity, they only have the type of activities that they are doing. It's not really very specific on the muscle strengthening activity. So that's why in cohort D and cohort E, they are also using this MAT score classification. Okay, so in terms of cohort D, where they are recruiting their population or their subjects with the data from 2015, so they have higher number of data compared with cohort C. So in cohort D, they would actually categorize it further into inactive, insufficiently active, active, and highly active MAT score. And then they also did the propensity score matching in cohort D to actually categorize it further into insufficient and also sufficient physical activity. And then in cohort D also, they actually subgroup their participants into subjects who actually tested positive for COVID-19, which is known as cohort E. So that's why they have 8 cohorts overall. Okay, so in cohort E, they don't do the propensity matching, only that they want to see those who tested positive for COVID-19. Okay,
Okay,
is
maybe
that,
we pause.
yeah.
Sorry, Iman. Please finish your sentence.
No, I just want to ask if anyone has any question on this cohort categorization. Yeah.
Okay, for those who have just joined us, you feel free to on your video and ask questions. For all this cohort, I think before we move on, you want to be very clear why 8 cohorts and who are they? Because many cohort in this study is actually meant to verify their result. Yeah. So if you look at the full paper, all these additional figures are in the kind of appendix. The one figure one in the paper would actually summarize all these 8 cohorts. Yeah. So get this clear in your mind. And the purpose is actually to verify the main analysis of the cohort A. Yeah, but then they are not so happy. They don't feel like secure and they're final. So they do further analysis by modifying a bit on their data set or looking at larger, slightly different data set, that kind of thing, and see whether the results hold on or not, whether the result concordant or not throughout. And as you can see in the result later, they are all essentially very similar. Okay. Feel free to ask any questions and comment anything. And feel free to on your video also and make the sessions more real. Okay.
I think if you're kind of shy to actually speak on the mic, you can actually you can also write your question on the chat box, so we'll address it for you. So in this study, so the authors actually clarified their sample size calculation, though that the sample size is huge. Okay? And this study, they actually claimed that the sample size was calculated based on a previous study that actually studied the relationship between COVID-19 severity and also physical activity. So they actually claim that they have 80% of power to show 2.8-fold improvement of severity among COVID-19 patients at 5 significant level that would actually require 900 patients at each group. So if we are looking at cohort A, which is the propensity scoring for cohort A, they have the final sample of around 1,002 in insufficient physical activity and also 1,002 with sufficient physical activity. But then in terms of this improvement of severity among COVID-19 that they are using in their sample size calculation, they don't really actually specify. The authors does not really specify what kind of improvements that they are looking at and what kind of formulas that they are actually using to actually calculate the sample size calculation in this study. Prof. Chu, do you think that sample size calculation is actually relevant if you are doing a large scale study? What is your opinion on this?
Okay. Before that is that you can, if you read the paper, the author justify that there isn't any study similar to theirs that they can use any estimated effect size for them to calculate the sample size lah. That's why you can see they use something that is close of 2.8 folds improvement. We don't know how many comparing groups of that 2.8 folds. It sounds like within one group, and that does not actually relevant to their study, because they're comparing different exercises categories on the outcome. But this is something they say there isn't any uh, effect sizes that is similar to theirs, and they use it kind of a bit forcefully lah. So the questions that Iman posed is that we can see from the sample size itself is actually quite large and large enough to actually getting the data set from the large registry usually, or it can be actually do not need a sample size calculation at all. You just show the result. Yeah, because its registry itself is so huge and so large, you cannot say, if you calculate the sample size, say they just need 500, what are you going to do with the extra sample size? You're not going to throw away. You're not going to just randomly pick them. You just include all of them because they are available at no cost. Yeah. Is there any other opinions or comments? Feel free to on your video and say anything. Okay. Yeah. Otherwise, we'll continue.
Okay. Okay, so to achieve the objective of the study, which is to determine the potential association between the physical activity itself and the risk of SARS-CoV-2 infection, the severe illness from COVID-19, and also COVID-19 related death, with considering of different confounding effects. So the authors of this study actually used the modified Poisson regression presented by adjusted related leave, ARR, with 95% of CI or multivariable analysis of covariance presented by adjusted mean difference with 95% CIs. So in this study, the authors actually using this Poisson regression is actually because it is more robust in terms of its variant estimation compared with the normal Poisson regression, and in considering that it has quite not like we are saying that it is a rare event, but then because they have quite a large sample of data. So to avoid any variance underestimation or overestimation, they're actually using this modified Poisson regression. And before they actually carried out their analysis, they actually have done several assumption analysis in which includes the linearity assumption of systolic and diastolic blood pressure, fasting blood glucose, and also serum total cholesterol using the box Tidwell test, in which that all these assumptions were actually non-significant. And besides that, they are also doing this normality assumption and also the homogeneity of variances assumption using the Levin test. Although that these assumptions are not all directly with are not directly related with Poisson regressions, but in my own opinion, that I think that the authors just want to be safe, so they actually check all these assumptions. Or do you have any opinion on this? Anyone have any opinion on these assumptions?
Perhaps Azifa would like to comment. Azifa, are you there? Are you guys the medical officer?
Yeah,
Yes,
yeah.
are you?
I'm here. So basically here we use Poisson regression, modified Poisson regression, which is a different kind not a different, just a kind of addition of Poisson regression, which we can use for binary outcome. And all the assumption, the linearity, normality, and homogeneity of variant is basically for a multivariate punya analysis for of assumption lah. So so for binary outcome, usually we can have two types of multivariate. If either we use a logistic regression or modify a Poisson regression. So for a logistic regression, usually the outcome is by the odd ratio, which we compare the outcome event over the number of event that not occur, as compared with modified Poisson regression. We use the relative risk, which is usually more clinician understand compared to the odd ratio. So I think I pass to Frostu and Iman lah.
Yeah, the other features of it is that the Poisson regression will is more appropriate if the events happens over a specified period of time. As you still remember, the diagnosis of COVID-19 has to happen between 1st of January to 30th of May 2020 in this study. So it's over a specified period of events. So Poisson regression of a count event is more appropriate than other type of multivariable regression analysis.
Yes. Okay, any other opinion? So I think we all agree that why the authors actually chose this statistical analysis like modified Poisson regression other than type of regression like logistic regression or the normal or the usual Poisson regression. Okay, so on top of that, the authors actually have all these three kinds of model of adjustment for their Poisson regression, in which that you can see that model one is adjusted based, model one is adjusted based on age, okay, and also sex. And then for model two is adjusted for age, sex, and also even more detail of confounders like region of residence. They have the Charlson Comorbidity Index. So Charlson Comorbidity Index is actually the categorization of comorbidities that a person or a patient have. So the higher the index is, or the higher is the comorbidities scoring, or the higher the comorbidity the patient has. Okay. And then a history of underlying disease like diabetes mellitus, tuberculosis, stroke, cardiovascular disease, and also other data like BMI, blood pressure, serum chemistry results like fasting blood glucose, serum total cholesterol, GFR rate, and also lifestyle and socioeconomic status as well. And then for model 3, they actually adjusted for minimal selected the potential confounders by a directed cyclic graph approach. So if you have the paper with you, the cyclic graph is actually on how you can actually look at the relationship between the exposure and outcome. So it is not actually very linear. So in between the exposure and also outcome, there would be confounding effects. There would be mediators in between the exposure and outcomes. Okay. And then on top of that, so this is the additional analysis that the authors done to actually test the stability and also reliability of the results. So this is not the main analysis to actually answer the research objectives. Okay, so this one is only to ensure that the results is reliable. So what did the authors do? So first, they actually analyzed two differential conditions. So if you can still remember, that there are two ways of analyzing the exposure or categorizing the exposure, which is, it is still the same to analyze or to assess the physical activity, but then the authors actually categorize it or differentiate the exposure using the recommended guidelines, the usual recommended guideline, which is in cohort A and cohort B, and the other categorization is based on the MET score, which is from cohort C to cohort E. And then besides that, if you still can remember on the match cohorts, okay, so the match cohort is based on the propensity score matching, in which that it is aimed to reduce the potential confounding effects. So they actually match the two groups to ensure that they don't have very wide differences between the two groups in terms of the baseline characteristics. So how did the authors actually did this propensity score matching? It is derived using the logistic regression model with adjustment, in which that it used to match the patient in two groups, in which that patients in the insufficient physical activity and patient with sufficient physical activity would not have a big difference in terms of their baseline characteristics. So we cannot say that a patient with sufficient physical activity could be younger. So they actually have adjusted all these confounding factors. Okay, and then besides that, the authors also have included the sensitivity analysis by generating cohort B and E, which includes only patient with COVID-19. So they only want to see patient who are actually affected or infected with COVID-19. So they have this cohort B and cohort C to actually see if the patient has already infected with COVID-19, what are the effects in terms of their severity, and what is the effects in terms of its whether they are at risk to die, or whether in terms of their length of hospital stay. Okay, so this is also one of the ways in terms of ensuring that the results is reliable. Okay, and then this one is what I mentioned on the directed cyclic graph, in which that it is used to confirm adequate potential mediators. So there would be a visualization of the causal relationship between the physical activity, which is the exposure, and also the risk of the outcome of the provided. So in between of the exposure and outcome, they would not be a linear. They would not be a direct. There would not be a linear relationship. So there must be a potential confounders in between the exposure and also the outcome. And besides that, there are also a subgroup analysis. So we can see that in table 3 later on, there would be a stratification of results according to age, gender, smoking status, and also the CCI, which is the Charlson Comorbidity Index, which have a statistical significance of interaction. And because this study involve large set of data, so they are actually at risk of type 1 error. So this study actually utilized the CDAC correction, which is used for multiple comparison to reduce the probability of type 1 error. Okay, any questions on this part?
Perhaps for many of us, we will feel very intimidated with all these complex statistical analysis. Yeah, but you want to just bear in mind that this paper has carried out, responsibly to verify their own result by doing slightly different statistical analysis to confirm their own result. Yeah, so this is one of the features of a good report and good research. If you want to know further of all the directed acyclic graphing and SEM, all that, you may want to study further. Yeah.
Okay, so this one is this one is based on the checklist of when we are considering about confounding factors. So in this study, important confounders actually have been identified, and in fact there are 3 models that the authors use in terms of using these Poisson regression models. And also they also have considered different confounding factors in each different Poisson regression model. Okay, so in terms of the follow-up, so for this study, they actually in cohort, especially in cohort D, they actually follow up the subjects or included the data of around like 5 years behind of the actual data or actual study itself, which is the actual outcome, which is the COVID-19.
Is there anyone who would like to disagree with Iman's response to the CASP checklist? If you have read the paper, you know later that the author themselves declare that they have not included all the confounding factors, but they did actually have included many. Yeah, of course it is not comprehensive. Yeah, so when you want to apply the result, you want to be aware of that potential confounding effect, residual confounding may be still there. Yeah?
Okay, so we will move on to the results of the study. So the authors actually presented the result based on the cohort. Okay, so first we will look at cohort A. So just for a refreshment, okay, so cohort A is actually based on the most original cohort in the study, in which that they have excluded those without the general health data. So it involved around 76,000 participants. So when you are looking into cohort A, so they actually categorize the subjects into age groups, and we can see that the age group is actually almost equivalently distributed, though that we can see that most subjects is in the 40 to 59 years old. Okay, and then in terms of the level of physical activity, we can see that majority of the adults, which is more than 50%, had insufficient physical activity, and only around 50% had both sufficient muscle and also aerobic physical activity. And in terms of the outcome, which is the COVID-19 infection, the severity and also the death, only from the 70,000, almost 76,000 adults or the participants, only around 3% were actually tested positive. And in this 3%, around 0.6% were actually having severe COVID-19 illness, and only 0.06% were actually related with COVID-19 death. Okay, so when you are looking at the age stratified outcome in terms of the COVID-19, majority of the subjects aged between 40 to 59 years old were actually infected with COVID-19. But then in terms of the severity and also related death, most that age more than 60 is actually related with severe COVID-19 and also COVID-19 related death. So actually in terms of this data, you can actually sorry, you can actually look at the supplement table in the paper itself. Okay, so when we are looking at sorry, when we are looking at table 2, we can see that firstly in terms of the COVID-19 infectivity, we can see that in model 1 and model 2 and model 3, all the 3 models, those who had actually sufficient aerobic and also muscle strengthening activity here actually has reduced risk of getting COVID-19. Okay, and then when we are looking at in terms of the severe COVID-19, okay, when we are looking at severe COVID-19 here, those who actually had sufficient aerobic and also muscle strengthening activity also has lower risk of getting severe COVID-19 here, regardless of the model here. All 3 models show significant reduced risk. And same also goes with COVID-19 related death. Okay, so all 3 models also showed that those who had sufficient aerobic and also muscle strengthening activity would have lower COVID-19, lower risk of COVID-19 related death.
Okay, allow me to just add on a bit. Also, you want to look at the middle 2 column, you don't see any beneficial effect. And you want also to see at the reference group. So all the result that the presenter just mentioned is there. You want to say is compared to insufficient aerobic and muscle strengthening groups. Yeah, you can see there's a 1.0 and REF, right? So this is a reference group of the effect size of having aerobic and muscle strengthening. But if you just did aerobic or just did muscle strengthening only, you can see that you don't reap any benefits from that exercise in this table, in this type specific analysis. Yeah. So if you want to enjoy the benefits of lower risk of getting COVID-19 infections and severe COVID-19 and COVID-19 related death, in this study and this specific analysis, you have to do both. Do you still remember what are they? What are these aerobic and muscle strengthening definitions in the study? So you want to bear that in mind, huh? All the benefits here, like say about 15% less lower risk of getting COVID-19 infections, and almost a 50% lesser risk of getting severe COVID-19. All these are if provided we did aerobic, moderate exercise half a day every day for 5 days per week. Yeah, or you have to do at least twice a week muscle strengthening, some aerobic kind of weightlifting or pumping, all that kind of things. Yeah, only then you can see the benefits of the so-called activity here, physical activity. Okay, so if you do any of that alone, the study show there's no protective effect. Okay, so this is what the table show.
Okay, so this one is based on cohort A, which is the original participants of the study without without any subgroup analysis. Okay, and then when we are looking at subgroup analysis of cohort A, we can see that those participants in age 40 to 59 years old actually have lower risk of getting COVID-19 if they actually do the aerobic and also muscle strengthening activity. Okay, and then in terms of sex, is male have lower COVID-19 infectivity, but this one is not really explained by the authors. And then in terms of smoking, those who are never smoked also have lower risk of getting COVID-19. In terms of the comorbidity index, those who don't have any comorbids also have a lower risk of getting COVID-19 if they are doing this aerobic and also muscle strengthening activity. Okay, and then in terms of the age groups, okay, those with higher age group actually have lower risk of getting severe COVID-19 if they are infected, because if they are doing this aerobic and also muscle strengthening activity. And the other parameters that is significant is also for smokers and also for the Charlson Comorbidity Index. So please note that like Prof. Chu has mentioned, so if there is insufficient of both activities, or if we are only doing one activities like muscle strengthening only or aerobic activities only, so it would not be different unless for female in getting severe COVID-19, and also in the smokers, and also for those with comorbidity index. Okay, so it seems that both activities actually provides protective effects in terms of getting COVID-19 and also the severe COVID-19 infection itself.
Okay, the other thing that you want to look at, there's something like dose dependent effect, moving from insufficient muscle aerobic and then combination of aerobic and muscle strengthening in terms of the effect size. Yeah, so you want to look at that as well. And why they report this analysis, because they found some potential interaction between exercises and this variable, and then they stratified it. They want to see which of this subcategory of the variables actually show the benefit effects. Yeah.
Okay.
Yes, carry on.
Okay, so in terms of the match cohort A, in which that when they match it into two groups, which is the sufficient and also insufficient group, we can see that the results is also protective against COVID-19 and also severe COVID-19. illness. But then the results here in terms of the related death is not significant here, but it could be due to low number of events, as we can see in our previous slide that there is only like 0.06% among the participants who actually died due to COVID-19. But then in terms of the infectivity and in terms of the severe illness, it has shown that both aerobic and also muscle strengthening activity sufficiently actually can actually decrease the risk of getting COVID-19 and also severe COVID-19. Okay, so now moving on to cohort B. So cohort B is particularly for subjects who actually tested positive for COVID-19. So we can see that among COVID-19 confirmed patients, that we can see that those with aerobic and also muscle strengthening activity has actually lower risk of getting severe COVID-19. And also in terms of the length of hospital stay is also reduced around 2 days with a adjusted mean difference of 2 days, around 2 days. So those who actually did sufficient aerobic and also muscle strengthening activity can actually decrease the length of hospital day by 2 days compared with those with insufficient aerobic and also muscle strengthening activity. Again, the COVID-19 related death here is not significant. It could be due to the low number of events, which is the COVID-19 related death itself. Okay, is that clear? Any questions on this part? Okay, so I'll move on to cohort C. Okay, so cohort C is the same like cohort A, only that the categorization is based on the max score. So that's why you can see that the number of participants is the same here. Okay, so when we categorize the subject into the MET or max score, we can see that those patients, you can see here, active here, those patients who have max score between 500 to 1000 max score, which is in the category of active, is actually protected against COVID-19. Okay, same also goes with severe COVID-19. Okay, it is also protective in terms of those who are having active max score and also the COVID-19 related death. But then please note that those with highly active, which is max score of more than 1000, actually has shown no significant effect here. So do you have any opinion, or do you want to share any opinion regarding this matter? Why those with highly active actually scored or have lower benefits of in terms of protectivity in comparison with those only with active levels? Any opinions or any sharing? Or Prof. Chu, do you have any opinions or any ideas on why does actually those who are highly active actually is not protective compared with active?
Okay, so this is a bit kind of counterintuitive, isn't it? You think that the more active we are, the more protective it will confer on us in terms of getting infections and severe disease, all that. But somehow or rather, this study and this analysis show unexpected result lah, we can say in that sense. However, as a practitioner of evidence-based medicine, this is the result as it is. I personally, I don't find any other statistical reasons that this is something fraud. But then what is left for us to think is that what could be the explanation for this lah? Yeah. So, and knowing that this variable, this exposure was actually 2018 to 2019, right? At the time before pandemic, and it cannot be highly active, pose them higher risk of getting the COVID-19 things. But the other possible reason explanation could be that too much strenuous physical activity could be injurious, could be doing harms to the body. As we know that if you're doing too much exercise, sometimes it can injure ourselves, right? And more inflammation instead of anti-inflammations. If let's say you got many injuries, sprain and strain, all that. Yeah, I mean, this is just my possibles. Too much exercise is not good. Probably, moderately active, and we know that exercises alone is not all that we want to go for. It's actually also the quality of exercise. Say when you do exercise, whether you're happy doing it or you're actually very miserable because you want to achieve certain level of exercise. I don't know. Yeah, but this study, if you go back to this result, it says in a way it's comforting lah. You no need to do very strenuous. So far we do something, but get away from inactive or insufficient, but probably up to a certain level. Do not need to be very, very highly active or very strenuous. I see someone like by the name of Rehab UPR. Maybe someone from the rehab side could give us some some light enlightenment. Is there a difference between highly active and active? No? Are you willing to say something about it? Yeah, maybe not, yeah? Okay.
Okay, so I'll just proceed with match cohort C. So match cohort C involve those subjects in which that their MET score has been matched into two groups. So you can see here on the table here. So from that fourth category of MET score, they actually categorize it into low physical activity and also high physical activity. So those with inactive and also insufficient physical activity will be categorized under this low physical activity, and those with active and highly active will be categorized as high physical activities. So you can see that all these, I think that my table is okay. So you can see that those with high physical activity is actually protective, okay, in terms of getting COVID-19, getting severe COVID-19 illness here, okay, but then it does not show any statistical significance in terms of protecting against COVID-19 related death. But this also could be due to low number of events, because from this cohort C, only around I think around 0.1% or less than it is actually related with COVID-19 related death. Okay, so we move on to cohort D. So cohort D is actually those we included from the year of 2015, which that's why they have higher number of participants compared with cohort A and cohort C. So they have around 118,000 of participants. So when we are looking at the level of physical activity, so majority of the adults, which is around 42%, is actually insufficiently active, and only around 3% is actually COVID-19 positive, and 0.2 is actually severe COVID-19, and only 0.1 is related with COVID-19 death. So when we are looking at the outcomes, okay, so we can see that in this group of participants, that all category of MET score, in fact, that if they are insufficiently active, it somehow has also protective effects against COVID-19 infection, okay, against getting severe COVID-19 and also COVID-19 related death. Okay, so I think this one is a little bit different with the previous cohorts, because this indicates that those who actually did some physical activities, although that it is not sufficient, so it also has some protective benefits here. Okay, any comments on this?
Remember, this cohort
related?
is they took from way from 2015 until 2019, so a larger cohort, and the exposure is measured in MET. So to me or to most of us, this may not be a useful outcomes measure because we can't measure ourselves. What is my MET? Yeah. So in that sense, it become less useful lah. This result. It will provided you know how you can measure yourself MET, then you can see that as what Iman was saying, just do some activity. It is likely to be beneficial. Yeah.
But I think one of the limitation also because this study does not actually, or the authors actually does not really specify or give the exact definition on what does it mean by, or how does the math scoring would be, like what kind of activities and what is the equivalent math score. So I think that one is also would be difficult to translate into practice. Okay, and then moving on to the match cohort D, which is using the propensity score matching. So we can see that the categories of high physical activity is actually protective against COVID-19 infectivity, okay, getting severe COVID-19 illness, and also COVID-19 related death, okay, compared with those in the low physical activity groups. So I think this one is consistent with match cohort C.
Ivan, sorry, can you go back one slide? See whether there's any those dependent effect, like just how the different from the lower active physical activity to the higher.
With the match cohort C, Prof. Is it cohort
this
C?
one.
This one.
Yeah, this one. The one with the different grades of physical activity according to MET.
This one.
Another one. You want to see the beneficial effect, whether there's any dose dependent effect. One more, the one that's all actually beneficial one, the one with all beneficials. I think the last cohort, the cohort D.
This one.
Yeah, this one. You can see whether there's any dose dependent effect or not. And it's actually concordant to the one that just how we mentioned about the one just active. Highly active may not be conferring you the most beneficial effect, isn't it? So this slide actually also concordant with the earlier slide. Though you can see they're all beneficial, but the one just active one is the one with most beneficial from the exercises lah. Yeah, you can see the effect, the lowest risk among all the three categories of physical activity. Yeah, can you see that? So in a way, it's actually again verify their result lah. Okay, thank you.
Okay, so when you are looking at cohort E, which is subjects from cohort D, which tested positive for COVID, so you can see that those who are actually active is actually beneficial to protect against all three, which is severe COVID-19, COVID-19 related death, as well as the length of hospital stay. But then I think this one is also similar with the previous one. Those with highly active participants who actually is not really protective against severe COVID-19, but then it shows some significant effects here on in terms of the COVID-19 related death, but then it is not again significant in terms of length of hospital stay. So I think we should highlight this category, the active group.
Yeah.
Okay. So is there any opinions or any additional or sharing that you want to share regarding the results, or we can just proceed with the discussion? Okay, so in terms of summarizing the results, so those who reported both sufficient aerobic and also muscle strengthening activities that met or actually exceeded the 2018 exercise guidelines has actually lower risk of the SARS-CoV-2 infection, severe COVID-19 illness, as well as the COVID-19 related death. So this one is based on the exercise guideline of 150 minutes per week and more than 2 times of muscle strengthening activity. But then when we are looking at the MET score, if the participants or the subjects is meeting the recommended target range, which is 500 to 1000 MET minute per week, it is actually associated with a maximum beneficial effect size for reducing the risk of COVID infection, severe COVID-19 illness, and also COVID-19 related death. So note that they actually highlight the key target range. So it does not really stated that we should actually exceeded the range. So this one is based on MET score. But then in terms of the activity guidelines, those who met or exceed the guideline can actually has the lower risk. I think in terms of the guidelines itself, this one is more practicable to be translated into practice, because in terms of the MET score, we don't know on how much score of the activity if what of the activities that we are doing. Okay, and then in terms of the length of hospital stay, so the length of hospital stay was actually shortened about approximately 2 days in patients who perform both aerobics and also muscle strengthening activity, or those with the recommended within the recommended target range of MET score, which is around 500 to 1000 MET score minute per week. Okay. And then what about a comparison with a previous study? So the authors actually have discussed that they actually have been a lack of studies in terms of investigating COVID-19 also physical activities, because most study actually focus on the health benefits of physical activity on the chronic diseases or the non-communicable diseases. And then in terms of the respiratory disease, there are also inconsistent results and also low level of evidence. So this is due to small sample size, the heterogeneity of the study population, short-term follow-up period, and also inappropriate study design, which is cross-sectional or either the uncontrolled cohort design. And when we're talking about the COVID-19 studies, previous studies also showed inconsistent results, and there are no association of physical activity with SARS-CoV-2 infectivity, severity, and also the beneficial association with the COVID-19 severity. So this is due to the available studies included only small sample size, whether they have uncontrolled cohort design, and also they don't really have standardized definition of physical activity and also statistical techniques to reduce the bias, and also different methods of collecting data for measuring exercise. So this can also contribute to inconsistent results in the previous studies. So what are the potential benefits of physical exercise against COVID-19? So these are all points that is being discussed. So it could be probably due to enhanced immunosurveillance because of the increased immunoglobulins, anti-inflammatory cytokines, okay, neutrophils, cytotoxic. So all these are immune cells. Okay, and then reduce systemic inflammation, in which that physical activity can actually induce or can actually promote the recirculation of immune cells, and also mediates an anti-inflammatory response and also antioxidants. And also it induces the expression of ACE2 in skeletal muscle, in which that the reduced circulating of ACE2 may have protective effects in the susceptibility to SARS-CoV-2 and also the severity of COVID-19. So this is how physical activity can actually induce or can actually improve immune system, and also be protective against the COVID-19 infection. So what are the strengths and limitations of the study? So the limitations of the study was actually indicated by the authors itself in the papers, in which that first it could be some recall bias due to the physical activity was assessed by self-report, and then the muscle strengthening activity is actually analyzed using binary variable, in which that it is based on whether they are doing it more than 2 times per week and not frequency data. So let's say that a person or a patient is doing 3 times per week, so it could be pulled together with those patients who are doing muscle strengthening activity like 100 times per week. So it could be pulled together. Okay, and then data of physical activity status was obtained at a single point of recent general health examinations, and they also exclude the light intensity physical activity. So for the type of physical activity is not really being defined in the study, and also there are also possibility of unexpected other confounding variables such as dietary practice or dietary patterns, and this study also only involve one type of population, which is the Korean population. So results should be interpreted with caution since there are any other important background variables that should be considered. And study was performed with data from the early stages of the pandemic. So in terms of infectivity, in terms of severity, they could be different now due to better management, due to due to vaccination status, and there are also probably some measurement error in some confounders, and also time varying nature of both exposure and many of the confounders. So it could not be uh, whatever data that is available in 2015, 2020 would not be the same like the current condition of the patient itself. Okay, and then we can see that there are many estimated CIs that can actually suggest sparse data bias. This could be due to low number of events, as you can see in the some of the data in the table. And lastly, they only included those patients who are underwent the testing, but then those patients with self-referral in which that they were tested anonymously were actually not included in the study because their data were unavailable, so it can increase in selection bias. Okay, so any other limitations or any other points that you want to share that could be included together in the paper as well?
A very good report would actually be very honest about their study, and the author and investigator themselves are actually the best persons to tell us what are the true limitations and what challenges and possible constraints of that piece of report and study. So if you when you ever we read a journal, if you when you come to these sections, if you find that it's very scanty and very like saying like nothing they would say about limitation of the study, you'll find that either the researcher themselves are not very clear of what they are doing, or they are very uncertain of what they are doing. Otherwise, they will actually be able to tell you there are many potentially so-called shortcomings. And reading and understanding this section will actually give you a very clear picture of the whole report and research. And at this point in time, then you will actually be very clear how are you going to apply and how much cautions that you want to bear in mind when you apply the result when in our life lah. Yeah. And if you want to discuss on this thing, there are many informative insights you can gain from just these sections. Yeah, but we will not be able to do that because of the times. And except if you have any particular issue you want to bring up, we can discuss one or two. Otherwise, presenter will go all the way to the end.
Okay, so in terms of the strength of the study, so this is the first large-scale population-based and also nationwide study to investigate the association of physical activity and also risk of COVID-19 outcomes and also the infectivity. And this study also used a validated physical activity assessment according to the physical activity guidelines and also the MAT score. And the other data that was obtained, such as the medical history, BMI, blood pressure, and also blood sampling, were actually measured or obtained by medical staff during personal medical interviews. So other than the physical activity, so the other important data were actually obtained by the medical interview, not by patient's recall or not by self-report. So. Okay, so what are the results? So this coming back to our critical appraisal checklist. So when we are talking about the results, so what are the results of the study? So you can actually ask yourself, what from your reading or from your appraisal, so what is actually the benefit of the physical activity itself? So from our discussion, physical activity has shown a potential benefit given that you're doing a sufficient amount, okay, in reducing the risk of COVID-19 infectivity, severe outcomes, and also related death as derived by the ARR values. And in terms of the precision of the results, we can look in terms of the width or the size of the CI, and also in terms of the sample size, the number of sample size that they have in the study. And in terms of the results, is the results reliable? So do you believe the results? So you can actually ask yourself. But then I think in terms of this paper, the authors have done quite a really good job in terms of reporting the results, in terms of ensuring that the results is sensitive, ensuring that the results is reliable, because they are also reporting that they are doing all this sensitivity analysis to ensure that the results is valid and also reliable.
Can probably we ask the participants, probably you can give some response whether you believe the result or not. If you want to use the icon, or you want to thumbs up or thumbs down, or you want to say something, because we would love to hear you more interactive in these sessions. How many will say you believe it, thumbs up, and how many will say no, I don't think, I either you don't believe it or you haven't really fully understood the paper, then you put a thumb down. Hello, are you all there? Do you see any thumbs up, thumbs up?
I don't see, Prof.
Okay. Any response? You're almost coming to the end.
Yeah. Nothing in the chat box.
Very shy, huh?
So when we are interpreting the results, one of the most important consideration is also whether the results can be applied to the local population, because at the end of the day, we want to apply the result of the research to our own population, right? So in terms of this study, maybe other lifestyle factors also have to be considered in terms of the socio-academic background, in terms of the culture, in terms of the dietary practices. And in terms of the results of the study, whether it is consistent with other evidence. So as we know that there are many known health benefits of physical activities in terms of disease risk reductions.
But I would say yes, isn't it? I would
Yes.
actually recommend people to do exercises when they can't. No need to be very active. I mean, highly active, because it helps in many other things. Although may not be, if you believe the study is actually directly has a effect on the immune system, isn't it? But even if you don't believe that, the effect of exercise could be on many other NCDs, risk factors, isn't it? I can see there's a chat from Bong Wan Xian, Norman KK. I think most of us came from clinical side. This is like refreshing session for us. Okay, all right. Thank you for your comment. Okay, so probably to Iman, you say can't tell because there are maybe kind of half believe, half don't believe with it. There could be many other factors. But don't forget about effect size. Some of the effect size are quite large, Though it's not, by convention, if it's any less than 0.2, then it's definitely very large. I think in 1 or 2, then it's not consistent. It's quite large, maybe up to like 50%, like in lowering the risk of getting severe COVID. Yeah. So there may be, I believe, direct and indirect benefits of exercising. Yeah, you exercise directly, immune's better, also reduce your weight, improve your hypertension, cholesterol, and good quality of life. There's endorphin, right? Make you more happy. and all that actually improve your immune system. Yeah. So I need probably, yeah, you probably want to comment on the checklist itself, lah. The checklist itself is not perfect. Why must I tick one of these 3 boxes? Isn't it? Can I tick, somewhere in between? Of course, yeah. Whatever you put it there, you just mention your reason.
Yes.
Okay.
Okay, so this one is what Prof. Chu has mentioned in terms of the implication of the study. So the recommendation of the physical activity itself in terms of directly improving the immunity. Okay, it can also help to manage weight and also reduce the risk of getting non-communicable disease as well, which as you can see that from the study that the CCI, which is the comorbidity index itself, can actually cause increased severity or increased risk of getting COVID-19 infection. So going down to the conclusion of the study, so what are the key messages that we can see from the study? So the results has indicated that those who engage in both aerobic and also muscle strengthening activity according to the exercise guidelines had a lower risk of getting COVID-19, okay, severe COVID-19 illness and also COVID-19 related death than those who did not exercise. And then in terms of the MAC score, so those who actually achieve the recommended key target range without exceeding the range was actually associated with the maximum beneficial effect size for reducing the risk of COVID-19 infection, severe COVID-19 illness, and also related death. And the length of hospital stay was also shortened for COVID-19 positive patients in approximately 2 days. And how might it impact on clinical practice in the future? The findings of the study suggest that the public health policies and strategies to increase physical activities in the population may actually reduce the risk of COVID-19 infection and also minimize the clinical consequences in patients who are actually diagnosed with COVID-19. And this also may have to be done something with encouraging individuals to have active level of physical activity, although that we are still in the middle of COVID-19 pandemic and should be actively considered to be publicized or to be encouraged at the public health level. Okay, so I think that's all for our MGH session for today. Do you have any questions or any comments in this sessions?
You may probably have something in mind about what about vaccinations? Most of us have been vaccinated,
Yes.
even got a booster, 3 doses. Yeah. So I would say the effect of the exercises may reduce. Yeah, because you have really got a higher protection from vaccines. Yeah. But how much less or how much is left of the benefits from exercises, we really don't know. So a good appraiser of any papers would actually then give you a very good suggestion of a good further study. Yeah, I would not be surprised if the same group of researcher repeat their study again, taking into their analysis the vaccinations status. Even just among all those who have been vaccinated, they can still see what's the effect size of the protective effect of exercises on their outcomes. Then we would be able to tell, whether it's still necessary to exercise after I got vaccinated. Yeah, I'm protected by vaccines, right? Would exercises, physical activity still confirm any additional protective effect or not? So we really don't know. Yeah. So this point would probably telling us something like a past lah. Unfortunately, and now that most of us have been vaccinated. Yeah. Okay. That's what my last comment is. Okay, we are very very kind and good participants to this sessions. How much we wish it can be more interactive, right? Okay, the one that you can see on the screen will be what we planned next month. if you feel this session is very helpful and you think you want to encourage your colleagues to join us, please do. You want to get updated with activity from CRU. We do have a Facebook. If you Google CRU HPPM, I believe you will be able to find our website and our Facebook. Just follow it. I think you'll get the latest activity on MJH next month. I think what's the date we tentatively been decided on 19, is it?
10th of December.
10th of December, yeah. But you'll find our final poster disseminated, probably end of this month.